Good afternoon, everyone. Dear Chair, dear audience, I'm pleased to present my PhD topic title, Impact of Navigational Systems on CT-Guided Interventions. My name is Mátyás Rédei. I work at the Medical Imaging Center, Semmelweis University, and throughout my PhD work, my vision is to improve CT interventions with advanced navigational systems for safer patients' outcome. And to reach these, we research the SS navigation's impact on CT interventions comprehensively. Therefore, we aim two specific goals in my first year of my PhD studies. Let's jump to the first one, investigating the safety and effectiveness of navigational systems for patients undergoing CT-guided intervention. There are a lot of kind of CT-guided interventions, such as biopsies, tumor ablations, drainages, sympathetic lysis, and they are very different type of interventions. But however, it's important to highlight that these interventions share a common, crucial first step, the needle insertion, which is a common procedure in such interventions. This needle insertion has to be precise because the reduced precision and accuracy leads to more complications since there's need for multiple needle navigation. As you can see, for transthoracic biopsies, there are about 20% of complications such as pneumothorax, and therefore, because there are multiple needle navigation, this procedure is very time-consuming and demand a long waiting list for patients. But what about we are using navigational systems for such interventions? With these navigational systems applied to these CT-guided interventions, the irradiation dose could reduce by half. The procedure duration reduced nearly 40%, and even the complication reduced by 7%. And our overachieving aim is to assess the safety and effectiveness of navigational systems, enhancing patients' outcome undergoing CT-guided interventions. So our clinical question is, does the navigation system, the integration of navigational systems in CT-guided interventions lead to reduction in complications compared to the conventional method? To address this, we compare utilization and non-utilization in patients undergoing CT-guided interventions to quantify outcomes such as number of needle manipulations and procedural time. As sub-outcomes, we can compare irradiation dose, complication rate, and success rate. So our hypothesis is that using navigational systems improve efficacy and safety in such interventions. And therefore, our clinical implication is providing recommendation for the appropriate utilization of navigational systems in order to enhance patient care. We conducted systematic search on 4 online databases. And we managed to hit about 20,000 articles. Here is a search key, which is separated in 3 domains. The first is the population, the second is the intervention, the navigational systems, and the third is the comparison group. Here is the flowchart. We could reduce by duplicate removal to 13,000, and we are after the title abstract selection, and it seems that there is more than 250 articles suitable for this research. And the full text selection is ongoing. Here is the project progress, and as we assessed multiple navigational systems, I would like to jump to my second project, which is involved just one and only navigational system, comparing the accuracy of a novel navigational system and conventional CT-guided method in pulmonary biopsies. In 2020, the global incidence of lung cancer reached more than 2 million, with Hungary leading it per capita rates. For histological diagnosis, the choice between transbronchial and transthoracic biopsy depends on the localization of the lesion or the tumor. Although the transthoracic one involves radiation and has higher complication rate, it is usually chosen for peripheral lung lesions. So our goal is to implement new navigational systems, not only to reduce procedural time, but to decrease complications as well. The following CT images represent the varying insertion frequency to reach the target in CT-guided pulmonary biopsy. The last image is shown the two most common side effects, the pneumothorax and the intrapulmonary hemorrhage. Our new navigational system, validated through a phantom study, not an in-human study, shows reduction in needle manipulation and reduction in insertion time. And without ethical approval to conduct biopsies in a human setting and to navigate in these biopsies, we want to validate our navigational system throughout retrospective measurement in human setting. Post-CT scan and planning, we measure the planned axis, and then we insert the needle to the target. Then here comes the part of the navigational system which is placed on the top of the needle. It can measure the actual axis of the needle, and therefore allowing us to compare target point error in millimeter in between the tip of the two axes and angular error in degree between the two clearly defined axes. So our primary inquiry is, does the navigational system predict more accurate needle trajectory during CT-guided pulmonary biopsies? To address this, we compare utilization and non-utilization of these navigational systems in patients undergoing pulmonary biopsies. And as a main outcome, we can quantify target point error and angular error. So we hypothesized that navigational system could predict more accurate needle trajectory. Consequently, the device could potentially offer a crucial advantage by accurately measuring the needle's position. I would like to end my presentation with the words of Liz Elling. There's so much gray to every story, nothing is black and white. Thank you for your attention.
I would like to congratulate you. It was an excellent presentation. My question is, maybe you know, how much do these navigation systems cost?
The cost of this navigation is varying from some $1,000 to more than $100,000. So that's why we want to address suggestions where and when to use them properly, because some clinics can only allow to buy one, and therefore we are conducting this meta-analysis.
It's very interesting. Thank you so much.
Thank you very much.
Congratulations, very nice presentation. So what are the main reasons why these CT-guided interventions are done other than lung cancer? And will you do different subgroups based on this?
Yeah, in the meta-analysis, we are planning to do subgroups if there is enough data available reported. And after the title abstract selection, we managed to find different data for different organs, so we can organize them specifically for different organs. And we would like to also to organize them into groups according to the different type of navigational systems.
Thank you.
So first, I have to congratulate you, but I have a little how can I say it to you? It's a little correction, because when we do a transbronchial biopsy, we don't use ultrasound. Yeah. We do it with the bronchoscope.
Thank you. I've deleted it in my PowerPoint.
Sometimes we do it under X-ray to see the malignant
tumor. You mean
tumor.
fluoroscopy? Just X-ray?
Just X-ray,
okay.
Yes. And we try to excise it. So, but I have a question for you. With this novel navigational system, how much does reduce the occurrence of pneumothorax?
Assessing this, we will find it after the clinical trial, but in advance we can say it's probably 5 to 10% the pneumothorax is eliminated throughout. There are less needle manipulation, which causes the lung to collapse and the pleural damage. So this is just an estimation in prior.
Thank you for your
Thank you very much.
Sorry.
You mentioned something about the ethics committee approval or without. I didn't get it. Can you just explain, please?
Yeah, sure. We do not have the ethical approval to conduct biopsies, to drive the needle with the navigational systems, but we do have the ethical approval to use it for measurements during these biopsies, to measure the excesses.
I still don't get it. I still don't get it, but it's, you have a very good ethics committee there.